Hello and welcome to Sleep Review's webinar, When to Prescribe Advanced Therapies for Patients Struggling with CPAP. I'm Sri Roy, editor of Sleep Review, and I'm here with three esteemed speakers, Drs. Mark J. Milbach, Barry Krakow, and Robert J. Thomas. After the three presentations, we'll answer as many questions as we can live. Submit your positive airway pressure-related questions via the Q&A box on your screen. Also, the slide deck is available for PDF download via the slide download and links box on the right side of your screen. This webinar is sponsored by ResMed. For the AAST credit, the CEC is available for the live webinar only, which applies to you if you're watching Tuesday, May 29th at about 12:15 p.m. Pacific time. Today's webinar is being recorded, but the pre-recorded version isn't eligible. On the registration page, you must also have said yes when asked about wanting the credit, which was the default. For privacy reasons, we won't be submitting the full roster to the AAST, only those attendees who requested the credit. So you must watch all three presentations and complete the exit survey on the left side of your screen. Even if you don't want the credit, we'd appreciate it if you'd take the survey. Once you take the survey, the form will simply close. If you don't get the certificate needed for the AAST credit by June 30th, email me at sroy@medcore.com. Let's start today's webinar with an audience poll. Please select from the choices on your screen. Then click the Submit button so we include your response in the calculations. When a patient with OSA is struggling with CPAP, what is typically your biggest hesitation to trying an advanced therapy? Inability to determine whether the patient will benefit. You know that the patient's insurance won't cover it. Patient's insurance might eventually pay, but it's not worth the time or effort, or you don't think the evidence exists that patients would be more compliant with a different therapy than they are with CPAP. If your main hesitation isn't on the list, you're welcome to type it into the Q&A box now as a comment for us to potentially share with the audience. And again, remember to click the Submit button so your vote is counted. And it looks like the vast majority of hesitation comes from patients' insurance won't pay for it. We've received denials for similar claims. And the second biggest hesitation at about 36%, inability to determine whether any given patient will benefit from advanced therapies versus continuing to try CPAP. And 9% say that they're not sure, they don't think the evidence exists that patients would be more compliant with a different therapy. Thank you for taking that poll. That gives us a good feel for today's audience, and we think today's webinar will give you practical advice for handling some of these scenarios. It is now my pleasure to introduce Mark Milbach, PhD. Dr. Milbach is the clinical director of the sleep centers at Clayton Sleep Institute. He earned his doctoral degree in applied experimental psychology at St. Louis University in St. Louis, Missouri. He's been working in sleep field since 1981. He is board certified by the ABSM and is a registered sleep technologist. In addition, he is an adjunct faculty member at St. Louis University, Department of Internal Medicine, and an adjunct professor at Webster University in St. Louis. Welcome, Dr. Milbach. We're ready to hear your insights.
Thank you. Thanks for asking me to partake in this. I have no conflicts of interest, probably because I'm not interesting enough to conflicts. But certainly a source of frustration for healthcare professionals and just any healthcare professional is compliance to treatment, whether it's medication, diabetics checking their blood sugars, taking their medications as they should, and for the sleep field, certainly assessing the ability to use PAP treatment routinely, reliably. That's certainly a frustration for many sleep professionals, but also for the patients themselves, trying to get used to it and being told just get used to it. Even with features such as heated humidity, ramp, pressure relief, people still struggle with PAP therapy. For some patients, maybe tolerance or intolerance is maybe they're just not on the right device. Several studies have looking at advanced PAP therapy devices such as bilevel PAP, auto-bilevel PAP, ASV, but many of these have mixed results. So my job today is to kind of go through some of these studies, and let's just review some. An early study, well, relatively early study in 2011, looked at auto-bilevel PAP with pressure relief. This took patients who had been non-compliant for 3 months, and their non-compliance was the typical compliance, what we think of as compliance. So for them, non-compliance was less than 4 hours per night over 70% of the nights. This study enrolled 35 patients, but only 31 of these patients completed. Most of these patients at the beginning of the study had been on auto-PAP. So they took this group of people and put them on auto-BiPAP with pressure relief settings. This first slide has the settings that they used in this study. Other studies that have used auto-bilevel PAP have very similar settings, so I do not have the specific settings subsequently. But they would set EPAP at 4 or 6, depending on what their maximum pressure had been. And IPAP was set at the maximum pressure setting. And then pressure support was 2, max pressure support was 8, and the pressure relief, or BiFlex in this case, was 3. They did follow-ups with patients days 15 and week 10. They didn't find any difference in the AHI between CPAP, the people who, when they were on CPAP and APAP, compared to when they were placed on bilevel PAP. So the bilevel PAP controlled their sleep apnea as well as APAP or CPAP. But there were improvements in compliance and subjective measures. So at day 15 and week 10, the days therapy was used was much higher compared to CPAP, APAP. Days used over 4 hours was improved, 61% compared to 19% during the initial therapy phase when they were on CPAP or APAP. And there was an increase in the mean number of nights used. There was a significant decrease in their Epworth score, and also by week 10, there was a decrease in the total FOSQ score, and that's Functional Outcomes of Sleep Questionnaire. Some issues with this is the sample size is pretty small, and is there just because people get attention during a study, maybe that improves their compliance. So some of these studies will show improvement in compliance, or maybe not, but sometimes just being paid attention to can help with compliance. Another study looked at patients who had an initial suboptimal in-lab titration. And for this study, the suboptimal titration indications were a sleep efficiency of less than 70%, 20 arousals per hour, or a CPAP titration was aborted by the patient, or there was persistent sleep disruptions during the night, and the judgment was made by the physician overlooking the report, decided they're not going to be compliant, or this is inadequate, so they could also be included in this. So all of these patients had a baseline apnea-hypopnea index over 15 or higher. There were 48 subjects who were included in this group. There was a CPAP group and an auto-bilevel group. The CPAP group had 22, 26 in the auto-bilevel group. They had a 90-day trial at home, and then follow-up visits at day 30 and day 90. They did subjective measurements of the Epworth scale, fatigue severity scale, and the FOSQ. And then compliance was measured day 7, 30, and there was a higher percentage of compliance in the auto-bilevel group versus the CPAP group, but that number decreased a little bit by day 90. However, even though they're different, they were not statistically different. I sometimes think there's a difference between clinical significance and statistical significance. So clinically, these may be significant. However, there is no difference in subjective scores on the Epworth fatigue scale or the FOSQ. Again, another issue with this study could be sample size, and maybe there's an issue with just the group that was selected. An initial poor night of in lab titration, is auto-BiPAP the best way to go? That's a good question. Another study, in some ways similar, was looking at auto-bilevel PAP following a poor titration. Now, these patients were a little different. They were either poor tolerance, but also another group that they looked at had no optimal pressure during their titration. So this study included 66 patients. 35 were in the non-responsive group, meaning that they couldn't find an optimal pressure, and another 31 were in the intolerant group. Both groups were placed on auto-bilevel PAP, and there was a significant decrease in their AHI for both groups compared to the AHI during the initial titration. In the non-responsive group, they were able to titrate them on auto-bilevel PAP and get an AHI down to 4.6 per hour compared to over 30 per hour on the CPAP titration. And then the intolerant group, their AHI dropped to 4.2 compared to 14.9. Now, again, these were people who cut their testing short, or there was no optimal pressure. So it could be that for the non-responsive group, they needed a higher pressure than 20. So they concluded auto-bilevel PAP was more effective than CPAP in treating sleep apnea in both of these groups. However, there's no subsequent compliance reports. So in some groups, bilevel PAP may be beneficial. Another study looking at ASV had looked at 42 patients diagnosed with severe sleep apnea and residual sleepiness. So their main goal was looking at people who were treated on PAP therapy but complained of sleepiness. They had these patients on APAP for 30 days, followed by a 14-day washout where they had no treatment, and then 7 days on ASV. And what they found was that compared to APAP, ASV significantly reduced AHI, reduced arousal index, and improved their Epworth score from over 10 to 4. So they chose this group based on their sleep apnea and residual sleepiness. However, most of these patients had some central sleep apnea during their initial testing and on APAP, and the largest change in AHI was a reduction in the central apneas. And again, in this study, there was no follow-up adherence. So this just goes along with some things that we know, that some people with central sleep apnea do tend to respond better with ASV. Another study looked at a large database from a Veterans Administration hospital. They looked at what kind of correlates are available for people who are prescribed bilevel PAP, and how do those differ for the patients who are prescribed CPAP, and do they differ for people who are prescribed initially CPAP and then later switch to bilevel PAP. Large percentage of males in this study. So what they found is they're just looking at a relationship between people who are placed on BiPAP and what kind of other health issues they have. They did find that the bilevel patients had a higher body mass index, higher AHI initially, higher incidence of congestive heart failure, higher incidence of COPD. During their testing, their oxygen levels went lower. They had higher blood CO2 levels, and they also had higher Epworth scores. Specifically, they found that age, higher BMI, severity of OSA, a diagnosis of COPD, increased sleepiness, lower SpO2 during testing, increased blood CO2. All of these were independent correlates of being placed on BiPAP. So all of these were strong suggesters that these patients may need to be considered to be placed on BiPAP rather than CPAP initially. And they also found that in the long term that the bilevel patients were more adherent than the BPAP patients. Another study that looked at a number of review articles looking at bilevel PAP versus CPAP. They felt that there's no strong evidence to switch over to bilevel PAP early on. That CPAP will treat the majority of people effectively. That in some cases, and they felt that this was not common, but in some cases, it may be beneficial for those who don't achieve a therapeutic level with CPAP or those who have persistent hypoventilation during testing. They think that additional research needs to be done to look at the long-term outcomes of bilevel PAP versus CPAP. Another study, this is a large database looking at CPAP users, ASV users, and people who are on CPAP and switch to ASV. So let's switch. So they found that the CPAP and ASV only groups who started out with ASV had 90-day adherence rates over 70%. Prior to switching to ASV, adherence rates were below 70% for those patients that were on CPAP prior to ASV, but then after switching to ASV, their compliance improved to over 70% after switching to ASV. So they believe that residual central sleep apnea was likely the main contributor to this group being poorly compliant with treatment. And another study looking at ASV, again, a retrospective study looking at a database, reviewed data from a two-year period. They identified two groups. They looked at people who were adequately titrated on CPAP or on bilevel PAP, and then also people who responded poorly to conventional PAP. Then they looked at the histograms of these polysomnograms for these people, and they identified three categories of people. They looked at people who had their respiratory events evenly distributed across the night, and they broke that down further into two groups, where people were normalized, their hypnogram was normalized during titration, and a two group was people who developed central sleep apnea during the titration. And then respiratory events that occurred mainly during REM sleep was the B category, and then C category was mainly respiratory events associated with non-REM sleep, which in this case tended to be more central sleep apnea. So group 1 had 80 subjects, group 2 had 43. So if we go back again, group 1 was adequately titrated and poor responders. There was no difference really between the groups on their demographics. The two main differences was that group 2 had more post-central apneas during the diagnostic study and had more of the type C hypnograms, which meant that they were primarily during non-REM sleep. So during titration, when comparing A1 types and B types to A2 types and C types, which would be more, if we think about it more, the obstructive versus central, the A2 and C groups had higher AHIs, higher non-REM AHI, higher apnea index, more treatment-emergent central apneas, and a higher number of patients who did not respond to standard CPAP bilevel. Group 2, the 4 responders to traditional PAP, 12 were successfully titrated on ASV, 28 were successfully titrated on bilevel ST, which has a backup rate, and 3 of them were not able to be titrated on any device. Another study by one of our speakers today looked at PAP and post-traumatic stress disorder. This was a retrospective review of a group of post-traumatic stress disorder patients who failed CPAP. There were 102 patients that they looked at. 64 were placed on ASV and 38 on auto-bilevel PAP. They looked at 3 compliance groups, over 4 hours per night, 70% of the night, which is the standard compliance. So this was the compliant users. There was those who were nearly compliant, 3 to 6 hours per night, but under the standard compliance criteria. So these were listed as sub-compliant users, sub-compliant but regular users. And then those who were over 2 hours, or around 2 hours a night or less than 2 hours. So these were the non-compliant minimal users. Other adherence statistics, other than adherence statistics, minimal difference between the groups. Several in the sub-compliant regular user groups were just shy of meeting the standard CMS compliance criteria. They had the total number of hours per week, but it wasn't daily. So one of the arguments could be, are our standards, should we be using these standards, change our standards? Do some patients need a longer adaptation time? And should other symptoms be included when trying to address compliance? Some people with anxiety or post-traumatic stress disorder may need a longer time than 30 to 90 days to become compliant. Okay, well, so that is about it for me, and I will move on and let the next speaker. The references are all listed here, and I will let the next speaker go.
Thank you so much, Dr. Muehlbach, for that insightful presentation and giving us a good feel for what the literature says. Now I am happy to introduce Barry Krakow, MD, who started in sleep research in 1988 and helped pioneer innovative therapies for chronic nightmares. Since 1995, he has practiced sleep medicine full-time and operates My Mind at Ease Sleep Arts and Sciences, a private center specializing in the treatment of sleep disorders in mental health patients within the framework of the mind-body-sleep dynamic therapy model. He's principal investigator of the Sleep and Human Health Institute, a nonprofit research facility that has published peer-reviewed papers on the PAP, the high prevalence of sleep-disordered breathing in chronic insomnia, and on the use of in-lab manual titration techniques for advanced PAP modes in CPAP failure cases, most notably PTSD patients, chronic complex insomnia patients, and other treatment-resistant OSA UARS patients. Welcome, Dr. Krakow. We're ready to hear your experience.
Thank you, Sri, and thank you, Mark, for an excellent talk. My talk is the Mode Not Taken, which describes our clinical experience dating back to 2005, when we first noticed signs and symptoms of CPAP withdrawal in our staff and in our center. It culminated in 2008 to 2010, where we actually were able to completely taper off of the use of CPAP and basically been using advanced PAP therapy ever since. By the way, these are my disclosures, which you have on your files. Just want to point out that we are completing our study with ResMed on a randomized controlled trial of PAP for chronic insomnia, ASV versus CPAP. And I'll have a poster presentation on that at the sleep conference coming up this coming Monday. In our clinical experience, there are 3 main areas, issues that so much influence what goes on in terms of the way we practice sleep medicine, and again, many mental health patients with sleep apnea. The first item is that there is no definition of CPAP failure. Unfortunately, we're all influenced by these terms called adherence, compliance, and so forth, which are non-scientific. They're insurance or government regulator driven. And they actually have very little, and in most cases, nothing to do whatsoever with the concept of CPAP success or failure. CPAP failure would obviously be defined patient-centrically as something like acute or chronic persistence. of patient symptoms or objective signs of poor sleep. Here's an example of a data download. We just took a random sample of a patient here, and you'll see the patient's averaging about 6 hours a night, has 100% compliance. This slide is put here to depict the fact that this has nothing whatsoever to do with CPAP failure. If this patient is still sleepy during the day, suffers from nocturia at night, still has awakenings, sleep fragmentation, nocturia, and so forth, they are a candidate for CPAP failure, which is crucial to the determination of whether somebody needs something else from the sleep center that can then be brought to the attention of the insurance company when appropriate, as needed. The second key barrier to our understanding and recognizing of CPAP failure is we don't have a definition of normal sleep breathing, meaning after an OSA or UARS patient has been treated. What is the endpoint? The American Academy of Sleep Medicine published over a decade ago the idea that you must eliminate apnea, hypopneas, and RERAs, and the RDI must be below 5 events per hour. At one point, there was even talk of doing a study on what is normal sleep breathing, what is normal sleep. To my knowledge, that has not been done. And unfortunately, this has created a very big conflict, in my opinion, or discrepancy about the way we look at the endpoint for our patients. The concept of normal sleep breathing should be a standard based on some kind of objective findings, and the findings we've chosen is what we've observed in normal sleepers who breathe normally. So, for example, back in 2003, when we opened up our sleep center, we recruited normal sleepers who breathe normally, and this is exactly the way their airflow looked. As you'll notice, this is exactly the way airflow looks on somebody who's getting a great optimal response to PAP therapy. And what we're talking about, of course, is the rounding of the inspiratory curve and the rounding of the expiratory curve. So this is the goal that we have been using for over a decade and a half that we're trying to reach in our patients when they are titrated with any PAP therapy. And what we discovered in 2003 to 2005 was how difficult it is to get to that place because of this problem. And this, of course, is flow limitation, otherwise known as RERAs, otherwise known as the discrete breathing events of upper airway resistance syndrome. Now, I believe everybody knows that these are abnormal, and everybody knows that, in fact, the American Academy of Sleep Medicine, more than a decade ago, mandated that these must be treated. This is not a consensus statement. This is not a something that's optional. I mean, this is, you must treat this in a titration study. That was the rule back in 2008. And so this is the third area of confusion, because if you're not clear on how to diagnose and treat UARS, then it becomes increasingly difficult in being able to manage patients on various types of PAP therapy, particularly CPAP. I'll just say it as an aside, it still is puzzling to me that UARS remains controversial. UARS has been linked unequivocally with daytime sleepiness, insomnia, hypertension, fibromyalgia, nocturia. So anybody who has only flow limitation, or RERAs, whichever word you like, and has that all night long, that is a sleep breathing disorder, whatever you want to call it, UARS, OSA, it doesn't matter. It needs to be treated. The problem, however, is how do you treat it? And here we get into the analogy that many of us, I'm sure, have used in talking with our patients, where we mentioned that OSA is a theory of a collapsible tube. When it's fully collapsed, you have an apnea. When you give it a little air from pressurized air, you now have turned the apnea into a hypopnea. Now it is a little bit more air, it's a RERA. But then you have to get to normalized air, which, again, to repeat, is not just the elimination of a RERA. It is actually attempting to normalize that airflow signal. In dealing with patients, we often use our hands, showing that this is the apnea with a collapsed airway. Give it a little bit of air, we have a hypopnea. Give it a little bit more air, we have a residual flow limitation. And finally, we have an open airway, which is normalized. The problem becomes in trying to titrate out these UARS events because amongst many patients who are anxious, and let me be very clear here, a patient who suffers from sleep apnea, although a speculative statement, by definition must have anxiety or almost always has anxiety because their body and their mind have been assaulted all night long with breathing events. Any person who suffers any type of breathing disturbance will develop some degree of some degree of anxiety. And that anxiety, therefore, is likely to be very common even in some classic sleep apnea patients. Anyway, people with known or unknown anxiety suffer discomfort, claustrophobia, panic. They may even blow off more CO2 from hyperventilation, develop central apneas. And the biggest issue then is when you talk to these individuals, and as we've mentioned, we spend a lot of time talking to mental health patients, and they frequently use these words. CPAP, in particular, feels like drowning in air. It feels traumatizing. And therefore, technically, CPAP is a traumatic stimuli. And the reason that's so important is that for a lot of patients, remember we have very low adherence in general when it comes to CPAP. And part of that reason, I believe, although it's difficult to get actual numbers on this, is because once you've used CPAP and had a traumatizing experience, you now suffer from a post-traumatic process, and you will in fact engage in classic post-traumatic avoidance behavior. And avoidance behavior means you will have attempted the CPAP briefly, maybe one night in the lab, maybe 1 week, maybe even 1 month. But the experience is so uncomfortable for you, and you rip the thing off at night, that you then not only give up on treatment in general, but the thought of using any PAP machine again may take anywhere from 1 to 2 to 5 years to resolve before a patient will begin again. When somebody is in fact fighting with PAP therapy, they end up with expiratory pressure intolerance. And in some cases, they end up developing central apneas as well. But the key here is not the central apneas. The central apneas are a tip of the iceberg. The real problem is that people who are on CPAP are fighting with positive airway pressure on expiration. And here's an example. In the bottom limb, the expiratory limb of the airflow curve, you can see this ragged or jagged edges, and these lines suggest the patient is fighting when they're trying to breathe out. And when you use advanced devices, you can make that go away. This would be central-like pauses, and this, of course, would be central apneas. But again, this is only a function. I'm only mentioning this, that this is a function of having to deal with insurance companies who believe ASV would only be used for people with central apneas. We are saying that expiratory pressure intolerance is the real key, even though we too must follow insurance guidelines on what type of device we can prescribe for someone. So the issue here is all about end expiratory pressure intolerance. Unfortunately, some training, to what extent I'm not sure, but some training is such that we focus on end of expiration in resolving apneas. But then what do we look at regarding hypopneas and flow limitation after that? I've been to many trainings where I've asked sleep technologists the question, have you been trained specifically to look at the expiratory limb of the airflow curve after eliminating apneas? And the majority of technologists tell me they are not trained to do that. And this is why it's such a big deal. We published a paper with our next speaker, Robert Thomas, about 5 years ago, describing that when you have expiratory pressure intolerance on somebody with CPAP or even somebody on another device, they will have abnormal arousal activity, excess awakenings, and they will have the failure to enter or maintain REM sleep. They'll also have excess sleep stage transitions. If you have expiratory pressure intolerance, it means you are failing to normalize the airflow curve. And in association with this, no surprise, you have patients with poor outcomes, persistent sleepiness, persisting insomnia, persistent nocturia. If you don't know, if you haven't studied the pathophysiology of nocturia, you should know that most people on PAP therapy should completely eliminate trips to the bathroom. If they don't, it is a likely reliable marker that something is suboptimal to their care. And what I'm getting at on this slide is this is how you go to an insurance company and you say, we have not been able to normalize the airflow signal. We have not been able to achieve high-quality slumber. The patient still has these residual outcomes, irrespective of how many hours per night they're using the device. So the key components, and this is a very important distinction to make compared to the great overview that Mark gave us at the outset. If you recall, he did not mention how anybody was titrated with the advanced devices in the lab. That's because in those studies they did not do it. They simply prescribed the mode, and they gave it certain settings. We put our patients in the lab on the auto mode. The sleep technologist observes very carefully what's going on with expiratory pressure intolerance and with flow limitation, and is aggressively manually overriding to fine-tune both inspiratory and expiratory settings. And then there is this special focus on REM that I'll bring up. Here's the first example that looks at a patient with CPAP, BPAP, and ABPAP. Depending upon your computer speed, these may go a little bit slow or fast. We'll see. In this first slide, you'll notice that somebody is on CPAP down at the bottom. They're on a CPAP of 6. And very quickly, they're going to be switched over to bilevel because they still had a certain amount of flattening or the patient was complaining. This may have been a second opinion patient who previously had failed CPAP, but we started them in the lab. You now see them on bilevel, 10/7, and you can see there's more rounding on the inspiratory curve for this patient. And as we go along, you're going to see right about this section that they're going to be switched to auto-bilevel. And this is one of the things that really sparked our curiosity, which was when this switch was made, the patient went into REM sleep, the green bars. And this was a very frequent finding that made us say, why are patients going into REM sleep so quickly after being switched to auto-bilevel or being switched to ASV? And the next example, we've got 4 modes that are going to be looked at. You can see we're down here with CPAP in the beginning, CPAP at 11. And this patient is doing terribly. They have flow limitation. They have expiratory pressure intolerance. They have residual breathing events. Clearly, something isn't working well for them with CPAP. Again, this may have been their first exposure, but in many cases, it represents second opinion patients we see who are failing CPAP. In just a moment, they're going to go to bilevel. And on bilevel, they went from to 14/12. And you can see that the inspiratory curve is showing some better rounding, but there's still a fair amount of inconsistency in this patient. In this particular slide set, we're going to jump ahead, and now the patient is on auto-bilevel. And now we have an odd finding, which is where the expiratory pressure intolerance seems to have gotten worse in some cases with the auto-bilevel. There's also some central apnea, as you may have seen, but there's also still some greater stability amongst the rounding of the inspiratory curve. And now the patient is suddenly switched further on, skipping ahead to ASV, and you'll see there is greater stability in that airflow curve on the ASV. And then the final example, I think people are now familiar with Morgenthaler's concept of split therapy protocol. And here, oops, try that again. Okay, here we go. These numbers are small, but there's only a couple of changes. It starts at 15/6 over pressure supportive 3. And you can see on this auto-bilevel patient, there is a fair amount of inconsistency already. There's central apneas. And you can see right here, the green bar, we're going to be approaching REM sleep. And from what I said earlier, this patient was switched on ASV before that, right here. And now we have 15/3. This is a max PS and then min, or just a regular EPAP for ASV. And you can see there is much more consistency of the airflow signal on ASV. And this study is several years old, and that's why there is no ASV auto in this particular study with 2 EPAP settings. This is just the one EPAP setting. And this slide now goes on for several more seconds showing that stability, so I think I'm going to jump ahead in the interest of time. So summing up these types of titrations, we're always looking for the problem of expiratory pressure intolerance and usually more suspicion in someone with overt anxiety. Well, you can still see it in people who have covert anxiety. We often find that CPAP yields a suboptimal objective response. And keep in mind, we have had tremendous success in failing patients on CPAP in the lab. That's the nature of the split therapy protocols. If someone does not tolerate CPAP in the lab, complains about it, finds it uncomfortable, or you cannot produce a good response, you can't get them into REM sleep, that is grounds for failure that has been widely accepted by the insurance companies that we deal with. And then, of course, we switched them to these various devices, and we do look for REM, and I'll give you an example of that right now. Here's a standard hypnogram. The green bars are REM sleep. Here's a patient who was diagnosed. This is back in 2007. We were going through this transition to advanced PAP devices, and we created a metric called REM consolidation index. You'll notice that there's all these discrete fragments of REM. So we take the total amount of minutes, divide it by 22, and we say REM consolidation is only 22 minutes. Anne Germain's research group has the opposite index that they've worked on called REM fragmentation index. This person was diagnosed, came back a couple months later for a bilevel titration. You could see they do very poorly in terms of improving the REM consolidation. There's still lots of fragmented REM, and there's central apneas at the end of the night. They come back a couple months later, again not doing well because of the central apneas. We decrease the bilevel pressures. There's a hint of some improvement in REM consolidation, but still not very much. Finally, they come back still a few months later, coming back each time because they're not doing well. They have persistent sleepiness, persistent insomnia, and they want more help. This is the first time using auto-bilevel. They have 100 minutes of REM. They have 11 REM periods. We're almost up to a REM consolidation index of 10. We want to see it above 15. Finally, a year later, as we learn more and more about central apneas and ASV, this patient was on bilevel for the first hour or so of the night, was switched over to ASV, and you end up with large blocks of REM that are very much consolidated. The patient was brought back even another time 6 months later for a retitration study to fine-tune pressure settings, and you can see that the REM consolidation is maintained. Now, the remarkable thing in this patient was all these things we've talked about that we use to describe CPAP failure in our patients were present, and they were decreased once the patient went to ASV. Less arousal activity and awakenings, greater REM sleep and greater REM consolidation, a decrease in sleep stage transitions, much more comfort to the patient, and of course the decrease in central apneas. So in summary, this patient failed CPAP even through desensitization, which is another place a patient can subjectively fail CPAP and can go on to an advanced device. They had only had modest improvement in insomnia, sleepiness, and fatigue, and therefore they were a candidate for something different. Only after the patient was titrated with ASV do we see those improvements. Now, this is the summary slides. Our model is to aggressively treat the re-raw breathing events. But to do that, we want to avoid triggering expiratory pressure intolerance so that we can get to normal breathing. And therefore, I'll leave you with this slide, which is, what if we stop looking simply at the number of breathing events? What if we flip the script? What if we start looking at the amount of time that somebody is sleeping normally, with normal sleep breathing, that is, by percentage and by minutes during the night? And if you're interested in that, all these remaining slides are something you can ponder over some night when you're trying to go to sleep rapidly. Thank you.
Thank you, Dr. Krako, for sharing your real-world expertise. Now a word from our sponsor, ResMed. ResMed AirCurve 10 V Auto is an auto-adjusting bilevel device that uses the comfort of the proven AutoSet algorithm and EasyBreathe waveform in its V Auto algorithm to treat obstructive sleep apnea patients who need greater pressure support. The device features V-Sync leak compensation technology that provides patient-device synchrony, tie control, time limits on spontaneous flow cycling, and adjustable trigger and cycle sensitivity settings. Now I am pleased to introduce our third speaker, Robert J. Thomas, MD, Associate Professor of Medicine and Director of the Sleep Medicine Fellowship at Beth Israel Deaconess Needham Sleep Center. His work is supported by the NIH Foundation and industry grants, and it spans brain health and sleep disorders, signal analysis innovation, and central sleep apnea syndromes. He champions a multimodal approach to treat sleep apnea, targeting driver and downstream phenotypes. Welcome, Dr. Thomas. We're ready to learn from your expertise.
Thank you for the introduction and the opportunity to present some of my ideas and insights. And I think it nicely complements what you have already heard. So I take a somewhat different approach from many in that instead of trying to make or use a more complex air pressure mode of therapy, I try to dumb down the disease so that it responds to less complicated therapy, which means one would need to use combinations of treatments. As sleep apnea is driven by multiple pathophysiologies, the upper airway being only one of them, it would make intuitive sense that we target the other drivers, potentially sleep fragmentation, which can come, of course, through multiple mechanisms, and abnormalities of respiratory control, especially high loop gain, which makes the respiratory control unstable. These instabilities do interact with air pressure devices. With CPAP, the device does not interact too much with the biology, while with an adaptive ventilator, the interaction is maximal. And whenever you have an interaction, you have the potential for both benefits and harms. I will definitely be talking about off-label stuff. I have some conflicts and support. Note the last one. The ASM recommendations are largely convenient, is driven by various needs. The patient's outcome is only one of them. And as we go through my slides, I'll point out why the current ASM recommendations don't quite fit the majority of patients who are having difficulties. Those patients who are doing well, about 50% of our patients, the guidelines work quite well. But once you go towards those who don't do well, we are left without any real guidelines, with inadequate data, and so on. So I call this a minimum approach to sleep disorder breathing, where you need to deal with mechanics, sleep, and control. And in an individual patient, one may be so dominant that is always needs to be targeted. So straightforward REM-dominant obstructive sleep apnea in a good sleeper essentially just needs the airway to be opened. You have a person with sleep fragmentation, PTSD, high loop gain, they probably need everything. A heart failure patient is another example of needing pretty much everything. You have a person with lifelong light sleep, insomnia, they can have sleep apnea or abnormal respiration just because the state fluctuation of sleep results in the unstable state driving fluctuating respiration. And if it reaches a certain threshold, one would call it apnea, hypopneas, and rares. So knowing what is the driver in each individual, singly or in combination, is key. Just to give a basic sense that the respiratory chemoreflex and obstruction is quite dynamic. It can change across a night, of course. It changes REM and non-REM sleep. A heightened chemoreflex drive is reduced by REM sleep. So a person can be extreme central, extreme obstruction, anything in between, and move around on a single night or multiple nights as body weight changes, as fluid status changes. So it is a far more dynamic system than we think or what we get covered for obstructive or central forms of apnea. The ICSD-3 and before that the ICSD-2 very much pushes everything we score into the obstructive domain. Maybe it didn't matter in the days when we had very few treatments targeting high loop gain, but now we are better off, and clearly we need to upgrade this classification. Those things like 50% of events need to be central is just made up numbers. It has no biological basis. You can't convince me that 40% central sleep apnea is somehow that much different from 51% or 49% central sleep apnea. So the way we score, the way we tabulate, so the literature is essentially contaminated by this strong bias towards obstruction. How do we detect a respiratory chemoreflex phenotype? There are ways to perturb stable non-REM sleep. And of course, one can do a readout of unstable non-REM sleep. A good example of a readout of unstable non-REM sleep is just the old-fashioned central apneas and periodic breathing. REM versus non-REM dominance is important. If you have non-REM dominant apnea, it is high loop gain. There is essentially no other explanation once you have accounted for body position. Of course, visual inspection. One can do mathematical mapping of the various signals too. The ways to perturb stable non-REM sleep, of course, in the sleep lab every night we go to bi-level and induce central sleep apnea without really wanting to. So that happens all the time, but you can do it in a more controlled way. So Jerome Dempsey basically measured end-tidal CO2 and applied bi-level and dropped end-tidal CO2 until central apneas appeared, and the difference between where you start and where you induced central apneas is the CO2 reserve. And the narrower the CO2 reserve, the more likely you're going to have air pressure or arousal-triggered respiratory instability. Andrew Wellman has elegant mathematical models focused mostly on non-REM sleep, where you partially dial down CPAP, allow obstruction, and then release again. And then you look at the ventilator response once you go back to therapeutic CPAP versus the ventilator response before you did that. Essentially, if you have a huge response to release of CPAP, it means that you are now responding to the buildup carbon dioxide in a more aggressive way. And that is another reflection of high loop gain. So the carbon dioxide reserve, loop gain, a hypoxic or hypercapnic ventilator response, these are all looking at different phases of the same fundamental set point of the respiratory control system. So how do you phenotype risk? It's actually quite simple. You just have to ignore all the ASM rules. So starting with, on the top you have a patient who has, well, by scoring criteria, obstructive sleep apnea. But note how the events are very self-similar. They look like clones. And below you have the same patient with CPAP applied. You have opened up the airway, but you have not fixed the abnormal rhythm. And this person is not going to be a success. Here you have the same patient, a different patient. In REM sleep, you see long cycle mild obstruction, while below in non-REM sleep, you see short cycle, about 25-second cycles of self-similar obstructive events. This person will respond very well in REM sleep to CPAP, but will completely fail CPAP in non-REM sleep. On a home sleep study, if you look at the respiratory events, the purplish blue one is the thoracic effort, then you have the oximetry. See how the events are self-similar. If you look at the PLET signal, the individual envelopes are almost identical. This patient has high loop gain sleep apnea and will fail CPAP or auto CPAP. You can have a very disaster-looking hypnogram, but there are two features here. One, you see the V-shaped desaturation of REM sleep. But in non-REM sleep, you see a thick band. So the more band-like or belt-like the desaturation is in non-REM sleep, the more likely you have high loop gain. This is a watchpad assessment showing REM-dominant V-shape desaturations and virtually no disease in non-REM sleep. And here you have both features. You have V-shaped desaturations and band or belt-like desaturations. The first patient will respond to CPAP. This patient in front of us will fail CPAP. Of course, we didn't touch on opiates much. Opiates is a completely different ballgame. Here you have a disintegrative pattern. Opiates affect numerous levels of the respiratory controller system. And what you see is drunken breathing. Opiates are not a focus of today, but this is just to give you a sense that it's a distinctly recognizable pattern with very high CPAP failure, almost 100% CPAP failure. So now you start someone on therapy, and you're hoping for the best. Well, sometimes it's not the best. This is a sample from Encore. A patient has ongoing respiratory events on fixed or auto CPAP. It's essentially Cheyne-Stokes respiration. Notice how several events are not tagged by the automated detection. Using machine-derived AHI is just not good enough. In fact, the machine-derived AHI of an adaptive ventilator is completely inaccurate. And I'm happy to discuss offline why that is so. And I have a paper in Sleep discussing why that is so. But you can't compare an AHI on CPAP in the same patient. You switch to an ASV, and then say the AHI has dropped from 10 to 0. It actually is not that simple. So this is what stable breathing looks like. And as Barry noted, what I try to do is give the patient stable breathing. So my target in clinic is to get to 90 to 95% stable breathing. And believe me, with a lot of effort, you can get there in virtually every patient. Complex apnea, central apnea, obstructive, PTSD, if you do it right, you can get to over 90% stable breathing because that is what normal physiology is. It's incredibly easy to recognize stable breathing. You can score it too, but it's very simple to recognize. This is an example of unstable breathing, which the device detection misses completely because this is short cycle periodic breathing and unstable breathing. This person actually has PTSD also and short cycle periodic breathing. And clearly, this is not a good outcome. So you have to visually look at the data. You just can't believe the machine-computed AHIs as of today. If your mask pressure, CPAP pressure is flying up and down, you have a problem. With ASV, you want to see stable pressure oscillations. The more the device is fighting the enemy, the greater the enemy persists. So in front of you, if you look at the red signal, this red trace, the stable thin areas are where there is completely quiescent breathing. Some of the clusters of fluctuations is REM sleep. But let me show you what a disaster ASV looks like. This is the patient on the ventilator fighting all night long. So you just can't apply ASV on a patient and walk off and think, you've done your job. It is simply a tool. You have to use it well. So this is a patient on CPAP, non-vented mask to stabilize carbon dioxide, acetazolamide, and zolpidem. We switch to ASV and all hell breaks loose. Same patient. So ASVs can dramatically destabilize patients, can dramatically help patients. You have to look at your data. So what can you do about failure? Well, you have to recognize it, obviously. So we can use oxygen to both prevent hypoxia and reduce loop gain. You can use sedative medications to stabilize non-REM sleep. You can manipulate CO2. You can use acetazolamide. Actually, acetazolamide, topiramate, and zonisamide, all of them can reduce high loop gain. And using these in combination, you can make positive airway pressure therapy work. You can even use combinations of these approaches with an oral appliance. And I'm guessing even hypoglossal nerve stimulation. Every therapy wants to be the king. Every therapy is pushed as this is the solution. There is no other complex disease. You take diabetes, ischemic heart disease. We don't try to make one treatment only work and stand just by that treatment. We target pathophysiologies at work. That's what we should be doing in sleep apnea. So this is an example of the power of CO2. This is pre-CO2, and this is when you add 0.5% CO2, you have complete stability of breathing. And this is another patient where you have, on the top left, you have central sleep apnea. You add 0.5% CO2, and you have complete stabilization of breathing. This is with CPAP. So when you add CO2 to CPAP, you just prevent the CO2 from going down. You don't need it to go up. You just need to keep it stable. And it works really very well. So we started using dead space to try to do a poor man's CO2 version, allowing a little bit of rebreathing. And it really works quite well. It is not as good as the device, I suspect, but really works quite well. And what it needs is to have a non-vented mask or a mask converted into a non-vented configuration. In the lab, you need an end-tidal CO2 measure. You need a whisper valve or some exhalation valve. And then, of course, you have the information about the worthiness of the seal. And how well can it work? Well, this is a person who had failed everything. And now this is with CPAP and dead space. He was my first patient. I saw him 2 weeks ago in clinic. It's 15 years of dead space and CPAP, and he's doing well. He's had 4 retitrations in between, and each time he looked exactly like he was untreated. So these monsters just don't go away easily. This is a patient with heart failure with unstable breathing. We add dead space, and you have now stable breathing. This is with CPAP, not alone. Dead space alone simply doesn't work well enough. Oxygen. Oxygen has a long history of central sleep apnea, and it does reduce loop gain. If you give 100% oxygen, you will shut off the carotid body, but we can't use 100% oxygen. And Andrew has shown quite clearly that oxygen helps a subset of patients substantially. And when you combine a sedative with oxygen, that's even better. It's so much harder to get oxygen these days, but that is how it is. As an example, you have a CPAP refractory patient, despite use of dead space. Now this is with dead space, there is some improvement, and finally we add oxygen and you have essentially far greater stabilization. So this is a person with distinctly mixed apnea, not central, where we have a combination here of air pressure, oxygen, and dead space. Acetazolamide, I used to use it only for my most extreme patients, but now we give it out like candy almost. We use very low doses, 125 milligrams, sometimes even half of 125 milligram tablet. It is intensely synergistic with dead space and with the CPAP. It works very quickly, so much so that we actually have the patient bring a tablet to the sleep lab, wake them up middle of the night, and you give it to them. You see the effect in an hour, so you really know whether it's working or not. And this is an example of how dramatically effective adding acetazolamide can be. In less than an hour, the person converted from what we affectionately call a monster on the top to a complete angel baby at the bottom. I have about 200 patients personally on low-dose acetazolamide, and we are tabulating our data right now. Sedatives. It's a misconception that sedatives kill apnea patients, at least not as a global statement. If you have REM-dominant apnea, you clearly do not want to mess with sedatives. But if you have non-REM-dominant apnea, where they look like high altitude, stabilizing non-REM sleep really makes a huge difference. I have a small number of patients with high loop gain apnea who I'm treating only with a sedative and side sleeping, about 6 of them. So this is how I use sedatives. I try to identify those whose sleep glue is poor, prolonged sleep-wake transitions, a high N1 despite air pressure, patients with anxiety, PTSD. These are people made for enabling sleep to be somewhat more stable. More recently, I've been trying suvorexant in patients with atrial fibrillation and heart failure who are very fragmented sleep with reasonable benefit. It's still too early to be sure it's better than, say, zolpidem, but that's a work in progress. So what about hypoventilation? Now, hypoventilation means elevated CO2, and hyperventilation and central apnea, periodic breathing, supposed to be hypocapnic. But, well, we have seen this little subset of patients. We have about 20 of them now we have identified who have hypercapnic periodic breathing. They're usually a combination of COPD plus heart failure or obesity plus heart failure. And they look, by all intent, they look, very periodic. But if you can see the CO2 here is 64, 65 millimeters transcutaneous CO2. So these hypercapnic periodic breathing patients, they're really difficult to treat, and we end up using acetazolamide, oxygen in supplement, and of course some PAP, could be CPAP, could be an ASV, but these patients are really, these are the worst to treat, and typically the heart failure plus COPD combination is especially nasty. Well, that's what I had to say, and the best way to learn all these funky techniques is to make a visit to Boston. We feed you dinner, and we teach you. You, of course, have to schlep out here for that. We can't really easily broadcast this and teach and take care of 12 to 14 complicated patients at the same time. So thank you.
Thank you so much, Dr. Thomas, for an excellent presentation with such important information. We are about to begin the audience Q&A, so audience members, if you haven't yet, or if you have a second question, please use the Q&A box on the left side of your screen to ask your questions about patients who are struggling with CPAP. If you are enjoying today's webinar, subscribe to email notifications about future events at www.sleepreviewmag.com/subscribe, where you can also sign up for a free print magazine subscription. Let's move on to the questions. Let me push this one out to the slide area. Okay, so the first one, and Dr. Muehlbach, I'll ask you this first since it came in during your presentation. It was about the literature review, but I think Dr. Krako also has experience with this. Would you know in the studies you were looking at, was EPR or Flex used with the CPAP or APAP devices?
There was one study identified that had Flex, and most of the others didn't, as far as I recall. I don't think any of the others did use Flex or EPR in their studies.
Excellent. And Dr. Krako, would you like to weigh in on your experience using EPR or Flex?
Yeah, the EPR and the Flex, they both have some utility in some patients some of the time. But in general, the EPR is probably better because it's functioning like a mini bilevel, yet you can't really get as much separation between the settings, so it usually doesn't work out that well. I know there's patients that use auto CPAP with EPR, the 1, 2, 3 settings, and they do report some better responses. We've actually seen some improvement with them in the sleep lab, but we tend to see a much better improvement with expiratory pressure tolerance being eliminated with bilevel, auto-bilevel, and ASV.
Excellent. And Dr. Kriko, I'll address this one to you first, which is as far as payers, handling the payers, how much time does it typically take you to get a payer authorization for advanced PAP therapy approved? And as you get more experience in doing that, does it take less time?
Well, I'm not sure the context in which the question is asked, because in our experience, we don't sell DME. So we are handing it off to a DME company. They go through all the paperwork. I think the area that we're most experienced with and is relevant is that if you go through this process during the desensitization, through the titration, and you describe CPAP failure. In other words, in the olden days, CPAP failure could be make the patient go home and use it for 90 days and come back and tell us what happened. That's not true. There is no formal definition unless some particular insurance company says, here's our definition. So there really isn't a lot of time involved in this. It's all about proving that there's failure. A patient who comes back to see you for their second titration who has lousy outcomes, you put him in the lab and you see the expiratory pressure intolerance, you see you can't get rid of the RERAs, you switch them over to bilevel, auto-bilevel, and so forth, you start getting a better objective response. The patient wakes up and says, I've slept better. That's now all in your report. That goes to the DME company, and your work is done. That shouldn't be denied. If it is denied, then I'm not exactly sure what the individual would have included. Again, it's all about proving CPAP failure and then proving that either from the point of view of the symptoms or the objective findings, and in most cases it's both.
Thank you. And Dr. Kriko, you actually have another question. Why do you think UARS is still so controversial? As a sleep tech, I read about it all the time, but in the lab environment, I'm told it is not something to pay attention to.
This question would take us several hours to go through, but unfortunately, I side very much with Robert Thomas's comments about the AASM. There's a lot of things that are going on there that are just not really keyed in to actual patient care. There's been many people who have been against the UARS conceptualization for decades. A big factor, unfortunately, is how people are influenced by what would be called consensus science or consensus policies. So if you have Medicare saying we don't cover UARS, well, that means that virtually everybody who works in sleep medicine is going to have somebody speaking into their ear whispering, there is no such thing as UARS because Medicare doesn't cover it. And of course, Medicare is not a scientific organization. Medicare is an organization designed to distribute health care in ways it thinks it can, but it has to save money. So a good way to save money is to not offer services to people with UARS.
That makes sense. Dr. Thomas, do you want to weigh in at all about why UARS is still so controversial?
It's the inconvenient truth, unfortunately. It takes a lot more work to deal with UARS, scoring it, titrating, tracking. It simply is a lot of work. It's not here's a machine, goodbye kind of thing. It is the inconvenient truth of sleep medicine.
Also makes sense. We have another question that I will push out so everyone can see it. And Dr. Thomas, we'll start with you on this one if you do have an opinion. Would it be advised to treat patients with sleep apnea, obstructive sleep apnea, as soon as possible, such as in adolescence, to prevent the development of anxiety-related expiratory pressure intolerance? Dr. Thomas, are you on mute, or I can send this question to somebody else as well?
Oh, is this for me?
Oh, yes, I thought I would ask you first, and then I think I'll ask Dr. Kriko as well.
So I think Christian Guilleminault is probably the one we should thank for pointing out that early treatment is key in preventing adult disease. And essentially, if you have sleep disorder breathing, by whatever be the driver in adolescence, it's probably going to stay with you. You're not likely to outgrow it. And this is going to be true for straightforward obstruction. It's going to be true for high loop gain. I have a patient I will be studying in my lab in June. Special night just for this kid, 15-year-old with, it seems like idiopathic central sleep apnea. His dominant symptom until someone did a sleep study was, as you may guess, ADHD. So I think early treatment is key. It's a tall order to treat an adolescent with sleep apnea. But you know what? There are some bad diseases which affect children, and they have to make their peace with it and do what is needed. What can I say? Some diseases are just not good to have. If you have insulin-dependent diabetes, it changes your life. If you have sleep apnea as an adolescent, it changes your life, but it is what it is. The benefits far outweigh, I think, any of the hassles once you just wrap your head around it.
True. Dr. Krejko, do you have any experience with this? If you can prevent the development of anxiety-related expiratory pressure intolerance?
Yeah, I'm not sure that the question is posed clearly, although it may be that I don't understand, what the questioner is asking. Most adolescents, if they're going to have a sleep breathing disorder at our center, it's going to be mostly UARS or a mixture of hypopneas and UARS. All of them are going to develop anxiety at the idea of having to use PAP therapy. In fact, we almost never do a full night titration on adolescents without first doing a PAP nap, because we want them to have the experience and be able to test drive PAP and then move on from there and have made their decision. So I think expiratory pressure intolerance is always going to be present in anybody who's going to be fighting with PAP, whatever the background is, young or old, it wouldn't matter. So I don't know that you can actually prevent something like that. And I don't think you can prevent the anxiety, so to speak, because you've got to, as Robert's alluding to, you've got to work with that patient to be able to get them to realize what are the risk benefits. And there's tremendous benefits to using PAP, but it is a fair amount of hassle factor you have got to overcome to be able to use it.
Thank you. Dr. Krejko, what determines whether or not a patient should be treated with ASV versus bilevel spontaneous timed mode?
Well, if I could make my recommendations, it's the concept that Robert's been talking about regarding, phenotyping, and I would say categorically when I see expiratory pressure intolerance, I would like to put everybody on ASV to see what happens. I appreciate, Dr. Thomas's work that obviously this isn't going to work with everyone, and there are going to be variations. But let me just point this one clinical pearl out. Many people think you can only get ASV if you have central apneas, or that is the coverage. It's actually not true. We've had several patients who failed CPAP, BPAP, auto-BPAP. Many of these are people who failed these devices at home. They've had horrible outcomes. This has gone on for years, and we suddenly make an appeal. We just bring the patient back in to the lab, put them on ASV. They report they're sleeping better. The objective findings show they slept better. We go to the insurance company and say, look, the patient's failed every other treatment. Why not cover this device so they can use it and get benefit? And in 90% of the cases where that's occurred, we have gotten coverage. I will say, though, I don't think you can get that to happen with Medicare.
Thank you. Would anyone else like to weigh in on this question about ASV versus bilevel?
This is Robert. So intuitively, ASV is going to be better than straightforward bilevel when you're dealing with fragmentation, high loop gain effects, pressure intolerance. Of course, the ASV has to be titrated well, not just slapped on the patient. So I agree with Barry that if we had the choice, trying to make the ASV work would be better. Also, Medicare is a hard nut to crack, but I do agree that other insurers, I've been able to get ASV with a little bit of effort, but Medicare, they're just so rigid, it's virtually mission impossible.
Understood. All right, well, in order to finish on time today, I want to conclude by saying thank you to our three presenters, our sponsor, and to our audience members. Today's webinar is being recorded, so you may rewatch for free anytime using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions, and visit us at www.sleepreviewmag.com. Thank you for participating in this Sleep Review webinar.